Okay, so the lungs are enclosed in the pleural cavity. How this hand is being put in a fluid-filled balloon like this, the lungs are developing. The lung bud invaginates into the pleural cavity. Here, see, this is the pleural cavity, and the layer of the pleura which is lining the wall of the lung, that is the visceral pleura, and the pleura which is lining the thoracic wall, that is the parietal pleura. Okay. So pleura is a serous membrane and it lines the pleural cavity. It has two layers. Inner visceral layer, this is the visceral layer which covers the lung, and outer parietal layer, this is the parietal layer which lines the thoracic wall and the mediastinum. The portion between the two lungs here lies the mediastinum. So parietal pleura also lines the thoracic wall, upper surface of the diaphragm and the mediastinum. Okay. So both the layers of the pleura are continuous with each other at the hilum of the lung and along the pulmonary ligament. So along, this is the root of the lung which connects the trachea with the lung. So along this root of the lung, this visceral pleura is continuous with the parietal pleura. Okay. See here, the development of pleura has been shown. Pleura, the two layers has been cut open. This is visceral pleura, inner layer. It lines the surface of the lung, and this is the parietal pleura which lines the wall of thoracic wall. Okay. Now here this blue one indicates the parietal pleura, and this pink one indicates the visceral pleura, and in between the two layers there is the pleural cavity. Okay. And these two layers are continuous around the root of lung, and in the middle there is the heart which is a part of the middle mediastinum. See here, this is development of the visceral and parietal pleura, that is invagination of the lung part in the pleural sac, which equates the invagination of the fist in the balloon. See here, this is laryngotracheal tube. From here, the trachea and bronchi are developing. From here, two lung parts are developing. These lung parts will enlarge in size and invaginate into this pleural sac. Okay. The green colored one here represents the visceral pleura, and the outer one, it represents the parietal pleura. Here also, like the invagination of this fist into the balloon, like this the lungs are invaginating into the pleural cavity. From the lung part, the lung is developing completely and it is surrounded by the visceral pleura. So this is the development. During embryonic life, fetus has two pleural sacs. Here, each developing lung part invaginates one pleural sac and gets covered by two layers of pleural sac. Here it is invaginating, and the lateral lung part expands to form the lung and start occupying the pleural sac, and layer of the pleural sac covering the lung forms the visceral pleura, whereas the outer layer forms the parietal pleura, and a thin persistent space between the two layers of pleura, it forms the pleural cavity. This is the pleural cavity is formed. So now visceral pleura, it is developed from splanchno-pleuric layer of the lateral plate mesoderm, and hence it receives its blood supply and nerve supply from the lungs, that is autonomic supply. In case of injury of the visceral pleura, there will be no pain, okay, because of this autonomic supply. And parietal pleura is developed from the somatopleuric layer of the lateral plate mesoderm, and hence it receives its blood supply and nerve supply from the thoracic wall. That is, somatic nerves are supplying this parietal pleura. So there will be pain in case of injury of the parietal pleura. Now, left pleural cavity is smaller than the right due to the space occupied by the heart. Okay. See here different parts of the parietal pleura has been shown. The greenish part, it is covering the thoracic wall, that is known as the costal pleura. It is lying against the ribs and the intercostal spaces. And this part, it lies, this bluish one, this is cervical pleura. It lies above the margin of the first rib. That is, at the root of the neck, it lies, cervical pleura. Now, this part, this violet one, it is lining the heart and the mediastinal structures, that is known as the mediastinal pleura. And this pink part, this is lining the upper surface of the dome of the diaphragm, that is known as diaphragmatic pleura. So, parietal pleura is divided into 4 parts: costal pleura, cervical pleura, mediastinal pleura, and the diaphragmatic pleura. So, pleura consists of 2 layers: inner visceral pleura, which is lining the lung, and outer parietal pleura. See, this is a schematic diagram of parietal pleura. The portion above this first rib is the cervical pleura. This portion, this is known as costovertebral pleura, lining the thoracic wall, that is inner surface of the ribs and the costal cartilages. This is mediastinal pleura, and here is the diaphragmatic pleura. So, parietal pleura is thicker than the visceral pleura, and it has 4 parts of subdivisions: costal or costovertebral pleura, diaphragmatic pleura, mediastinal pleura, and the cervical pleura. These are the 4 parts. This parietal pleura can come as a short note. Okay, this is an important question for you. Now, costovertebral pleura, previous name is costal pleura, it lines the inner surface of the thoracic wall and separated from the thoracic wall by endothoracic fossa. Endothoracic fossa is loose areolar tissue which separates the pleura from the lung. And diaphragmatic pleura, here is the diaphragmatic pleura, it found adherent to the superior surface of the dome of the diaphragm and continues on the sides with the costovertebral pleura. Here it is continuous with the costal pleura and medially with the mediastinal pleura. Now, cervical pleura, also known as copula, dome-shaped part of pleura, covers the apex of the lung. Here is the cervical pleura. Extends into the root of the neck about 5 cm above the first costal cartilage and covered superiorly by the suprapleural membrane or Simpson's fossa. Okay, yesterday you learned Simpson's fossa. It is attached along the inner margin of the first rib. Okay, so it covers the cervical pleura. Now, mediastinal pleura, here in this part, it covers the medial surface of the lung and forms the lateral boundary of the mediastinum, and it is continuous with the visceral pleura along the hilum of the lung and the pulmonary ligament. See here, this extension of parietal pleura below this root of the lung, this extension is known as the pulmonary ligament, and here it is the root of the lung. Here the structures are entering and also coming out from the lung. This is principal bronchus, right principal bronchus dividing into apatrial and hypatrial bronchus, right pulmonary vein. Here are the pulmonary arteries. Here vein is carrying oxygenated blood, that's why it is colored red, and artery is carrying deoxygenated blood, so its color is blue. Okay, and the extension of parietal pleura below this root of lung, This is known as the pulmonary ligament. And along the pulmonary ligament, there is continuation of the pleura. Now, what is pulmonary ligament? It also comes as a short note, pulmonary ligament. Okay. So, pulmonary ligament is a double-layered fold of parietal and extends inferiorly from the root of the lungs. Along the root of the lung and pulmonary ligament, the parietal pleura is continuous with the visceral pleura. And what are the contents? It is the space with loose areolar tissue, few lymphatics, and sometimes accessory bronchial artery. So these are the contents of the pulmonary ligament. Now the relations of the pulmonary ligament, medially it is related to the esophagus, laterally mediastinal surface of the lung, superiorly hilus of the lung, and inferiorly it ends in a free sickle sepate contour. Okay. What are the function? Function is important. It provides the potential space. Pulmonary ligament provides the potential or dead space for expansion of the pulmonary veins. During excessive blood supply, there will be engorgement of this pulmonary vein, and this pulmonary ligament, this potential dead space, it accommodates this expansion of the vein. Now, it also permits descent of the root of the lung during inspiration, and pulmonary ligament provides space for descent of the root of the lung during the descent of diaphragm and pulls the lung downward. Now the recesses of the pleura. There are two main recesses of the pleura, costodiaphragmatic recess and costomediastinal recess. See here, these recesses are enlarged spaces within the pleural sac. Costodiaphragmatic recess, in this part, it is lying between the diaphragmatic pleura and the costal pleura. And here, this is the costomediastinal recess. It is lying between the costal pleura and this mediastinal pleura. So, what are the recesses of the pleura? It is potential or reserved space of pleural cavity that lies between the parietal pleura and visceral pleura. What is the function? It provides a potential space for lung expansion. And number of pleural recesses, two major pleural recesses are present on each side. These are the costodiaphragmatic recess and costomediastinal recess. And two minor recesses are also present, that is retroesophageal recess. It is present on right and left side, and infracardiac recess. Okay. So these are the recesses of the pleura. This can also come as a short note, recesses of the pleura. And this costomediastinal and costodiaphragmatic, these two are important for your radiology. Okay, these are if there is accumulation of fluid in case of different diseases like pleural effusion, this recesses is obliterated in the X-ray, chest X-ray. So, the recesses are the potential spaces of the pleural cavity. Costodiaphragmatic recess lies inferiorly, lies between the costal and diaphragmatic pleura, larger and most dependent recess. And costomediastinal recess, it lies anteriorly and lies between the costal and mediastinal pleura, and left recess is larger than the right due to the cardiac notch of the left lung. Okay. And what is the function? Provide space for lungs expansion during deep breathing. And what is the clinical aspect? In pleural effusion, fluid accumulates in the costodiaphragmatic recess. And in chest radiogram, there will be obliteration of the costodiaphragmatic angle. That's why this is important. These recesses are important. See here, this is the costodiaphragmatic recess on the two sides in between the costal pleura and diaphragmatic pleura. And here is the costomediastinal recesses in between costal and mediastinal pleura. And see on the left side, the costomediastinal recess is larger than on the right side because of this notch in this lung. This notch is cardiac notch. Okay. And here you can see the costomediastinal pleura in transverse section. This is coronal section. In this transverse section, you can see this costomediastinal pleura. Okay. So costodiaphragmatic recess also called phrenico-costal. Phrenico means diaphragm, lying between the diaphragmatic and costal pleura. That's why name is given phrenico-costal sinus. Cleft-like potential space between costal and diaphragmatic pleura here. Length is about 5 cm in the mid-axillary line and location it extends from 6 to 8 rib in the mid-clavicular line, 8 to 10 rib in mid-axillary line and 10 to 12 rib in paravertebral line. This extent is very important. Extent of lung is in the mid-clavicular line up to 6 rib and in the mid-axillary line 8 rib and in the paravertebral region it is 10 rib. That's why in pleural effusion the aspiration of fluid is done at 8th and 9th intercostal space, that is below the 8th rib to prevent injury to the lung. Here only if you pierce from this part, there will be no chance of injury to the lung. Okay. It forms the most dependent or lowest part of the pleural cavity. Hence, fluid in the pleural cavity in pleural effusion tend to accumulate in this recess. See here, this is the costodiaphragmatic recess. This is 8th rib, here is 9th rib, 10th rib. So below the 8th rib will be the 8th intercostal space and here 9th rib, below the 9th rib, 9th intercostal space. In these two spaces, needles are pierced to collect the fluid in the costodiaphragmatic recess in case of pleural effusion. Okay. And this is the lung outline, so there will be no chance of injury to the lung. So space, next is the costomediastinal recess. This is the costomediastinal recess and here this one. Space that lies anteriorly behind the sternum and costal cartilage. This is sternum, so these spaces are lying behind the sternum. And right costomediastinal, it is lying between the costal and mediastinal pleura. Here you can see. And right costomediastinal recess is normally occupied by the anterior margin of the right lung, even in quiet breathing. And left costomediastinal recess is larger, less occupied than the right, due to the presence of cardiac nodes of the left lung. You can see it is larger, left one. Now the intrapleural pressure, that is important. This is important for your MCQ and Viva. Intrapleural pressure is always negative. It is minus 4 mm of Hg. Okay. And retrospinal, other two recesses has been discussed here. Retroesophageal recess, it is present on right and left side and it lies posteriorly between the costovertebral pleura and the mediastinal pleura and it lies behind the esophagus. That's why the name esophageal recesses. Now infracardiac recess, it lies only on the right side and it extends behind the inferior vena cava. And normally the pleural cavity contains 5 to 10 ml of serous fluid. This is also asked in Viva. What is the amount of pleural fluid? Normal amount. Okay, 5 to 10 ml of serous fluid is present in the pleural cavity. And in case of disease, the amount can increase. Okay, no nerve supply. Parietal pleura is pain sensitive. Intercostal nerves supply the costal and peripheral part of diaphragmatic pleura. and phrenic nerve root value is C3 to C5 and central part of the diaphragmatic pleura. Okay, and visceral pleura, these are the somatic supply, parietal pleura. Okay, and visceral pleura, it is insensitive to pain because there is autonomic supply supplied by sympathetic. Autonomic supply means sympathetic and parasympathetic. So sympathetic supply will come from T2 to T5 segment and parasympathetic supply from the vagus nerve. Okay. Now the blood supply, parietal pleura is supplied by internal thoracic and musculophrenic arteries, and visceral pleura supplied by the bronchial arteries. Here, this is the normal costodiaphragmatic angle. This angle you can see clearly. This black portion is the lung. This is dome of the diaphragm. Below it, the liver is present. That's why this is opaque in color. And here it is obliterated costodiaphragmatic angle. You cannot see the costodiaphragmatic angulation due to the pleural effusion. Collection of fluid has occurred in the costodiaphragmatic. In visualization of chest radiograph, you have to see these points, whether the angles are obliterated or not. So, pleural effusion, important clinical aspect, it can come as a explain why. In pleural effusion, costodiaphragmatic recess is obliterated. It can come as a explain why question. So, in pleural effusion, accumulation of fluid occurs in the pleural cavity and angle costodiaphragmatic angle between costal and diaphragmatic parietal pleura on the radiogram of thoracic region will correspond to the costodiaphragmatic recess and it lies between the diaphragm and chest wall. See here, diaphragm and chest wall. And normally it is sharply pointed downward and measures about 30 degrees. This angle is known as costodiaphragmatic angle. And accumulation of fluid in the costodiaphragmatic recess, as this is a most dependent part of pleural cavity, pleural effusion tends to accumulate in this side and there will be obliteration of the costodiaphragmatic angle. Their obliteration has occurred in pleural effusion. And in pleural effusion, the chest radiograph shows obliteration or blunting or widening of the angle. Okay, now referred pain. Okay, the parietal pleura, mainly the mediastinal pleura or some part of diaphragmatic pleura is supplied by phrenic nerve C3, C4 and C5 and these roots are also supplied in this region, lower part of the neck and shoulder region. So in case of pleural injury, there will be referred pain in the lower part of the neck and the shoulder region. So referred pain of pleura, pain arising from parietal pleura is referred pain to the lower part of the neck and shoulder region because phrenic nerve root value is C3 to C5 which supplies parietal pleura and same nerve roots are also supplying the neck and shoulder region through the supraclavicular nerve. There also root value is C3 to C5. Okay. This can also come as explained why referred pain of the parietal pleura can refer to the shoulder and lower part of the neck. Okay, this is also explained why question for you. Now, atelectasis, that means lung collapse. Loss of negative intrapleural pressure, normally it is -4 mm of Hg, results in lung collapse or atelectasis due to recoiling property of the lung. Next is pleurisy, this or pleuritis and pleural cramp. This is also a clinical aspect. Pleurisy is inflammation of the pleura and cause is viral infection, most common cause. Tuberculosis or pneumonia. Pneumonia is infection of lung and so on. And inflamed rough surface of pleura produce friction sounds during respiration. And these sounds can be auscultated and this is called pleural cramp. Okay. The surfaces of pleura become this rubbing occurs in between the two layers and they become rough. That's why a sound is produced during respiration. And this oscillated sound is called the pleural rub. Okay. Now in pleural effusion, thoracocentesis is done below the eighth rib, in the 8th or 9th intercostal space. This is the costodiaphragmatic recess of pleura, and this blue colored one, this is fluid accumulation in the costodiaphragmatic recess. And see here the needle has been passed along the upper margin of the rib, not at the lower margin of the rib, because there is an important neuromuscular bundle along the costal group, the band structure, vein, artery and nerve. So in case of if you place the needle here at the lower margin of the rib, there is chance of injury to this neuromuscular bundle. So needle has been put along the upper margin of the rib. Okay. These are collateral branches, these are small branches. So there is less chance of injury here. So what is pleural effusion? It is excessive accumulation of fluid in the pleural cavity. Normal amount is 5 to 10. Here the amount will be more. And types of pleural effusion based on the accumulation of fluid, pleural effusion is classified into these types. Hydrothorax mean accumulation of serous or transuded fluid. Pneumothorax mean accumulation of blood. And empyema or pyothorax accumulation of pus. Chylothorax is accumulation of chyle, and hydropneumothorax accumulation of fluid and air. Okay. In all cases, there will be obliteration of this angle. Treatment, what is the treatment? There is thoracocentesis. It is aspiration of excess fluid from the pleural cavity and treatment of underlying infective cause. Okay. And procedure, a cannula or needle is passed through the lower part of the 8th and 9th intercostal space in mid-axillary line to avoid injury to the neurovascular bundle. This also comes as I explain why the needle is placed along the upper margin of the rib to prevent injury to the neurovascular bundle. Okay? And in which space the needle is placed, that is also important. To prevent injury to the lung, the needle is placed in 8th or 9th intercostal space. Okay. Also asked in Viva, also important for explain why. See, this is pneumothorax and collapsed lung. In external injury, the pleural lung has been, pleural cavity is open to outside. The air can enter into the pleural cavity, but it cannot come out due to the black valve mechanism here. Okay? And this, due to entry of air, the intrathoracic negative pressure is lost and lung has been collapsed. Atelectasis or collapse of the right lung. Okay, pneumothorax, accumulation of air in the pleural cavity is called pneumothorax. Normally intrapleural pressure is always negative, but because of pneumothorax, pressure becomes positive and it causes collapse of lung or atelectasis and shifting of the mediastinal contact to the opposite side, and it will push the mediastinal contact in between the two lungs to the right side. Causes are injury to the thoracic wall and pleura and spontaneous rupture of the pulmonary bulla. These are the causes of pneumothorax. Now another tension pneumothorax. This is a surgical emergency. Occurs when the air can enter in the pleural space but cannot escape, and it occurs due to valvular air passage, one-way entry. Here I have told the flaps helps in entry of air, but air cannot come out from the pleural cavity due to the flap valve mechanism. And signs and symptoms, it causes collapse of the lung and impairment of respiration, hyperexpansion of the chest and deviation of trachea to the opposite side. Treatment is surgical emergency, surgically correction of the injury, and thoracostomy. It involves insertion of a needle in the second intercostal space in the mid-clavicular line. Okay, this is the treatment for thoracostomy, for pneumothorax. Okay, that's all. Any queries regarding pleura? Okay, any queries regarding today's topic? Any of thing you have not understood? Which one? SAQs. Okay, those I was telling, explain my questions. See here. This clinical aspect, pneumothorax, then this one, SAQs, why the needle is pushed into the 8th or 9th intercostal space. This is also explained my question. Okay, to prevent injury to the lung. And another is why the needle is placed along the upper margin of the rib. Why not along the lower margin? Because along the lower margin in the costal group, neurovascular bundle is lying. So if you place the needle near the lower margin of the rib, there is high chance of injury to this neurovascular bundle. There is chance of nerve damage or there may be bleeding. Okay. So to prevent this, you will place the needle along the upper margin of the rib. So this can also come as a explain why question. Another thing, why this costodiaphragmatic angle is obliterated, okay, in pleural effusion. Because of it is the most dependent part of the pleural cavity and fluid accumulates when there is infection, fluid accumulates in this costodiaphragmatic angle, costodiaphragmatic recess. That's why this angle is obliterated in chest radiogram. Okay. This also comes as explain why or short answer type question. And nerve supply of pleura is important. Okay, why there is pain in injury of the parietal pleura? Because it is supplied by the somatic nerve, intercostal nerves and phrenic nerve, and visceral pleura is supplied by the autonomic nerve. So there, in case of injury of visceral pleura, there will be no pain because it is insensitive to pain. But in case of injury of parietal pleura, there will be pain, and pain is referred along the distribution of phrenic nerve into the shoulder and the lower part of the neck. Referred pain of the parietal pleura. And these are important for your MCQs. Normal amount of fluid lying in the pleural cavity, 5 to 10 ml of serous fluid. And the intrapleural pressure, it is always negative, minus 4 millimeter of Hg. Okay. In pneumothorax, this pressure becomes positive. Okay. And the recesses can come as a short note. Okay, costodiaphragmatic, costomediastinal. These two you have to must write, and rest two you can write esophageal and some pericardial. Okay. And the different parts of the parietal pleura. Parietal pleura mainly comes as a short note. 4 parts: cervical pleura, costal pleura, mediastinal pleura, and diaphragmatic pleura. Pulmonary ligament, it also comes as a short note. Okay. Those I am telling which comes as a question, you prepare as a short note. Okay. Pulmonary ligament, you have to describe its formation, content, function, and relation. Okay. Relation you may not write, but rest of thing you have to write. Formation, content, and function is very important. And it can also be asked contents of the pulmonary ligament. During your viscera, lungs viscera, you have to see there will be table of viscera for thoracic viscera. It will have the lungs, heart, and the diaphragm. Okay, so it can be asked during the viscera table also content of the pulmonary ligament. Okay, so there will be lymphatic, some loose areolar tissue, and sometimes accessory bronchial artery. And these are the different parts of the parietal pleura. It can come as a short note or long question, part of the long question. It can also come parietal pleura. Okay. Development of pleura, you have to know just for your knowledge how the lung parts are developing. Okay. Okay, that's all. Any queries? Okay, thank you.
How many of you who have attended my previous class, that is isozyme and clinical enzymology, how many of you have read? Yes, there are 4 students yesterday in that batch for whom I took the SGD, responded only 4 students. What about the rest? Did anybody read enzyme? How many of you have read enzyme? 1. See, if you do not read after attending the class, you can imagine what you will do in the examination. Don't think that one time reading will make you expert and you will be able to answer. So as I realized yesterday that none of you have read whatever have been told in the class. So in this class, try to be very much attentive. Try to remember whatever I am saying so that you don't require reading also. Even if you require reading, it will be easier to understand. The topic which I will be covering in most of the classes will all be clinically relevant, and that will be required for clinical practice. I will share some of my experiences which all are not written in the book, but you must remember, and something which I will tell in the class also, which are not available in your books, but in future classes, in the 4th year, 5th year, you will get it, because at the end of your tenure, you will be doctors and you will treat the patients. So this knowledge will be translated into clinical practice. So today I will cover hyperbilirubinemia. Why this topic is important? Because this is related to jaundice. So jaundice is a common disease, relatively common disease. In the OPD setup, maybe in a district hospital or in a subdivisional hospital, at least you will get 1 or 2 cases per day. There are 3 different types of jaundice. One is hemolytic jaundice, one is hepatic or hepatocellular, and third one is obstructive, about which I will tell in detail. But before you understand all the 3 types, you must know the fundamental basis of bilirubin production, and then will you realize in which condition all these jaundices will appear, will be found. And I will take a separate class on liver function tests, which will be required during clinical practice. And at the end of 1 year, you must be expert to interpret a report without seeing a patient. And that's my target. And if you cannot do it, then perhaps I will consider myself as my own failure. So, hyperbilirubinemia, slide. Hyperbilirubinemia means increased level of bilirubin. So, let us see what is normal bilirubin. এখানে একটু কাজ করছে না, হ্যাঁ কিবোর্ড থেকে আছে। First and foremost, how many of you will tell why does porphyrias occur? Anybody from the last bench or in the middle will volunteer? Why does porphyria? What is the cause? Basic cause. It was, one question was there. But have you read, if any one of you have read, what are the questions that have been asked in the theory paper? If you don't read that one, then what you will understand, you know? It is not possible. Why does porphyria, or I should say, why do porphyrias occur? It is in plural sentence. Why? What is the problem? Bola. Tell. Huh? Inborn errors of metabolism? Yes, correct. For of what? Heme synthesis, correct. Inborn errors of heme synthesis. So, why inborn errors of heme synthesis will occur? Why inborn errors of heme synthesis will occur? Tell me. Just volunteer. I want some amount of interaction also. Because if you don't know how heme is synthesized, you will not be able to tell why porphyria occur. So you see, this is the heme synthetic pathway, and there are a number of enzymes which are involved. If these enzymes, if any one of the enzymes is deficient, obviously the reaction will not proceed further, and there will be a block, and that will cause porphyria. So defective heme synthesis will lead to porphyrias. In contrast, once this heme has been, now what is bilirubin then? Or what is bilirubin? Can anybody volunteer? What is bilirubin? Yes, anybody else? Any idea about bilirubin? Bolo. Hemoglobin
has two parts, heme and globin part.
Hemoglobin has food?
Two parts.
Huh.
Heme and globin part.
Heme and protein? Heme and
Globin.
globin?
Globin goes to amino acid food and heme is degraded to biliverdin, then degraded to bilirubin.
Correct. He has said the essence of what I am going to tell today in today's class, the entire process. Heme is catabolized to biliverdin first and then to bilirubin. Sit down. So, what is bilirubin? Bilirubin is basically yellow or orange yellow, red orange or red yellow. It's basically, remember, it's a yellow colored pigment or compound produced from a normal catabolic pathway of heme, that is obtained from hemoglobin of RBC. That is what is bilirubin. During heme synthesis, perhaps this structure have been told. It's tetrapyral ring. There are 4 porphyrin rings which makes bilirubin. So what is the RBC? Mature RBC is produced. What is the fate of this RBC? RBC has a limited lifespan of 128 days on an average in a healthy individual. Remember, what I am talking about right now are related to healthy individuals, not of disease. So lifespan is 128 days. So after that, that cell will die. Now that dead cell will be taken up by the reticuloendothelial cells present in the spleen, bone marrow and the liver. So, as he told correctly that hemoglobin has two parts, one is globin and one is heme, that is composed of porphyrin and iron. Globin is degraded because it is a protein, so that protein will be degraded to amino acid and it will be in the amino acid pool. Similarly, iron will go into the iron pool and rest is porphyrin. That porphyrin will be broken down to heme. Now, as the RBC ages, say from day 1 to 120 days, RBC will age, and senescent means aged. So, how do you recognize an aged person or old person? How do you recognize? There are some markers. There are some markers by which you recognize whether it is a old person, an old person, or it is a child, or it is an adult. So, there are markers. So, that senescent RBCs is also having markers, and these reticuloendothelial cells acts as checkpoints, as guard, security checking. So, this senescent RBC, that is aged RBC, will be taken up by the macrophages. That is called erythrophagocytosis, because it will, erythro means RBC, so it will be erythrocytosis. It is mainly by the spleen and also in the liver and marrow through recognition of a range of senescence markers, because otherwise how will that reticuloendothelial cell will differentiate whether it is a normal cell or it is an aged cell or old cell. So, after phagocytosis, there will be hemolysis and reutilization of the other components, as I told, that is hemoglobin and iron, globin and iron. So, you must not remember at this stage, but try to remember the way how you recognize an aged person. It is similar features. So, there will be morphological alteration. The skin of an aged person is not that of an adult. The hair of a person, aged person, will not that of an adult. So, there will be morphological alterations, including decreased cell volume and changes in cell shape, and that is how it will recognize that this is normal, it is not a normal RBC. And there will be qualitative and quantitative modulations. See, you have read the anatomy, the structure of plasma membrane. There will be loss of aspartate aminotransferase and esterase activities. There will be surface modulations. There will be number of oxidative stress, such as phosphatidylserine externalization. Some of these modulations are recognized by the reticuloendothelial cells as a senescence marker, and that is why they engulf. That is why they are called phagocytosis, not the normal RBCs. This part is not written in your book. So, site of production, this you must remember. What is the site of production of bilirubin? So, it is basically in the RE cell of spleen, bone marrow and liver. And catabolism of heme from all proteins is predominantly from hemoglobin. It is done by the microsomal system. This heme oxygenase is present in microsomal system. Now, during this time, this slide is right now irrelevant, but I told you because at one point of time you must be asked one question that what are the heme containing proteins and what are their functions. It might come as a short note, they might be asking some questions, and at that stage at least you must be able to tell and what are the heme containing enzymes. So this might come as a short note, that's why I have mentioned it. So heme containing proteins also will release hemoglobin, but that amount is minimal. The maximum amount is from RBC. So from senescent RBC, hemoglobin will be released, heme will be formed, and heme will be processed or metabolized in the reticuloendothelial system by heme oxygenase to biliverdin. And then from biliverdin, there will be reduction and it will cause unconjugated bilirubin. Now you see here, this part, this bond, it's a double bond here. This has been reduced. This is single bond, and that is caused by biliverdin reductase. And remember one thing, because of this structure, hardly there is a hydroxyl group here, or CH group. So bilirubin is sparingly soluble in water. Remember, there are some words which are very important, like sparingly soluble. That is a catchword. It's essentially a nonpolar molecule, but sparingly soluble. It's not that soluble just like sodium chloride or glucose because of this structure. Then this unconjugated bilirubin which is formed is transported to the liver by albumin. This is another step. Bilirubin, as I told, it is sparingly soluble in water. So therefore, it needs to be bound to something which is soluble. Albumin is soluble. So it binds to albumin, and then it is transported to the liver. One molecule of albumin can bind 2 molecules of bilirubin, and in 100 ml of plasma, approximately 25 milligram of bilirubin can be bound. In clinical situation, you will be giving some drugs in different conditions. So that drugs compete with the bilirubin binding site of the albumin and will displace it. There will be false elevation of bilirubin. So in an otherwise normal individual, if you find some bilirubin elevated until proved otherwise, you rule out whether the patient has taken any drug which can displace bilirubin. Have you been told about liver in the anatomy? Is there any class? There is no need to. Hello, I told you not to use mobile. Nothing will happen. This is recorded. You can see the recording. The moment you use mobile, I will stop and simply leave this class. You listen here and you read this book. If required, you go through this video lecture. You will be able to recollect. See, further metabolism will occur in the liver. If you have read liver and if you understand the histology, then only you will be able to understand this thing, otherwise not. Because this, if you cut the liver and make a histopathology, you will see lobular structure, and if you further enlarge it, you will see there are central veins, there are blood vessels, there are sinusoids. So So, without understanding this thing, it will be difficult to comprehend what I am going to tell. So, that albumin-bilirubin complex will reach the sinusoidal surface of the liver, hepatocytes. It is liver, not hepatocyte basically, I would say. So, where there are three phases will be there, this you must remember. One will be uptake, one is conjugation, and the third point is secretion. I will tell briefly in a short while in detail about the three phases. So, further metabolism of bilirubin, once it is taken up by the liver, being carried from reticuloendothelial cells. So, it will be taken up by the liver, it will be conjugated, and then it will be secreted into the bile. So, uptake. In the hepatocyte, if you see that histopathological structure, you will see there will be a sinusoidal surface. So, that sinusoidal surface where this blood will flow, it is a large capacity saturable facilitated transport system is there, it will be taken up by that thing. Now, just like glucose, once it is internalized, it is converted to glucose 6-phosphate, so that it cannot come out. The same mechanism is here. Once bilirubin is internalized, bilirubin binds to cytosolic protein, that is glutathione ACE transferase. Earlier it was called ligandin when we are students, to prevent from re-entering into the cell, blood. So, it will not allow to come back again into the circulation. Now, this part is very important and it will be usually asked in examination in Viva, conjugation of bilirubin. So, bilirubin, as I told, it is a lipophilic and non-polar substance, it is pairing soluble. It needs to be converted into a water soluble form because it needs to be excreted in the bile. So, it is conjugated with glucuronic acid by bilirubin, by a bilirubin specific UDP glucuronidase transferase. In the enzyme class, you have seen that enzymes are classified into 7 classical groups. And the second one is this EC numbering, that is enzyme commission numbering. This second group is transferase. So, basically this is a transferase enzyme. So, rest of the numberings you must understand what are the meaning of the rest of the numberings. So, it is a specific enzyme and that is present in the endoplasmic reticulum. As I told you earlier, this heme oxygenase system is also there in the microsomal fraction and conjugation takes place at the endoplasmic reticulum. So, by the glucuronic acid under UDP gluconyl transferase, or just tell simply gluconyl transferase. These two are catchwords. You must remember. Bilirubin is conjugated to glucuronic acid by the help of gluconyl transferase. So, just I summarize this part. I stopped here, unconjugated bilirubin. So, unconjugated bilirubin will be converted to conjugated bilirubin with the help of UDP glucuronate, that is gluconyl transferase enzyme. So, it will be converted to conjugated bilirubin. So, conjugation takes place, again I am telling you repeatedly so that you remember, you must not forget this UDP gluconyl transferase. In the first stage, one molecule of glucuronic acid is added. So, it will form bilirubin monoglucuronide. Now, the second phase, one more glucuronic acid will be added. So, it will form bilirubin diglucuronide, and it is in this form bilirubin is excreted because it is more water soluble. 2 molecules of glucuronic acid is added to bilirubin. So, once it is formed, it is secreted, this conjugated bilirubin is secreted into the bile. It is not basically bile, it is biliary canaliculi. In the histopathological section, at the cellular level, this is happening. So, bilirubin has been conjugated by the hepatocytes after being taken up by the sinusoidal surface, and now this conjugated bilirubin will be released into the canalicular side so that it enters into the biliary system. So, bilirubin is excreted in the form of bilirubin diglucuronide normally. You see here this structure, I have enlarged it, this biliary canaliculi, because once you read the histology of anatomy, this liver, then you will be understand and you will be able to correlate that histopathological picture with the biochemistry and the anatomical structure also. I will tell you in briefly so that it will be easier to understand. So, this is a complex mechanism, it is not that easy. So, I have not dealt it how the bilirubin transporter proteins act and transport protein. So, this you remember, right now you will be reading anatomy and you will be able to understand the basic fundamental concepts. So, liver is located here on the right hypochondrium. So, if you see the liver structure, see biliary canaliculi will join to form intrahepatic bile ducts. These are present within the liver. Just like drainage system, multiple drains from multiple points will converge into a big drain, and from another big drain, another drain will join, and finally, say suppose the water drain from the area from this Santiniketan Medical College, a number of drains which will be connected and finally the water will be coming out. Same thing is here. So, intrahepatic biliary ducts will combine, and there are two lobes in the liver, one is right lobe, another is left lobe. So, there will be two ducts. So, right hepatic duct and the left hepatic duct, and that will combine to form the common hepatic duct, and through that the bile will enter into the gallbladder, where it will be concentrated. And when a fatty food will be taken, that gallbladder will contract and the bile will appear from, bile will be expressed from gallbladder through the bile duct into this first part of the duodenum, second part of the duodenum. You see this structure here. Can you see? This is cystic duct and this is the bile duct. This is right hepatic duct, this is left hepatic duct, this is left hepatic duct, this is right hepatic duct. They are combining to form common hepatic duct, through which bile is entering into the gallbladder, and from gallbladder again contraction cystic duct, it is passing through, this passing through. Now, note the caliber here, it is almost uniform. So, bile will flow normally, this is a normal bile duct opening in the duodenum. Now, this is deliberately I have taken to explain a little later, this is from cancer bile duct. So, that part is narrowing. So, bile will not be able to flow from biliary duct to intestine, and that will cause obstruction to the flow of bile. And once there is an obstruction to the flow of bile, that will cause obstructive type of jaundice. This is one example, that is why deliberately I have taken. So, any problem in this region will cause obstruction, right from this part anywhere. Suppose here if there is a block, that will also cause some amount of obstruction, but the major obstruction will occur if there is something in the bile duct, right from here up to the opening. So, that is the importance of this picture. Second thing is that after this bilirubin is excreted in the duodenum, it will reach into the terminal ileum and the large intestine, and it will be converted to urobilinogen by the intestinal bacteria. So, after conjugated bilirubin reaches the terminal ileum and large intestine, glucurosyl moieties which has been added by the liver will be removed by the bacterial glucuronidase, and subsequent reduction of bacterial flora will convert it into urobilinogen, and small portion will be reabsorbed and re-excreted via enterohepatic circulation. And the oxidation of urobilinogen will form to urobilin, and in the stool it will form in the form of stercobilinogen. So, bilirubin, the fate of urobilinogen is that it will, a part of that urobilinogen will be reabsorbed into the portal system, and it will undergo enterohepatic circulation. Entero means from intestine it is going to liver. So, enterohepatic circulation. So, again that will move, but some part, major part will be excreted through the stool as stercobilinogen. Now, you have noted, if you have seen the stool in the open air, it will cause darkening, and that is due to conversion of stercobilinogen into stercobilin. Similarly, urine on standing becomes, if you pass a high colored urine, means concentrated urine, if you observe it, one day you observe after passing urine, high colored urine, you will see the color of the urine has changed, and that is due to conversion of urobilinogen to urobilin. So, if a high amount of urobilinogen is passed, so that stool color will not be normal, it will be dark on exposure to air. That I'll tell you. So, in the intestine, bilirubin is converted by the bacteria to stercobilinogen. This is fecal urobilinogen basically, and colorless urobilinogen will oxidize to stercobilin, which imparts color to the feces, and darkening of feces, as I told you, in the air will cause to oxidation of the residual urobilinogen to urobilin, and basically in the stool it is called stercobilin. So, just to sum up, so senescent RBC will be taken up by the reticuloendothelial cells, conversion from heme to biliverdin to bilirubin, taken up by the liver, conjugation bilirubin diglucuronide, it will be excreted, and in the small intestine and in the large intestine it will be degraded to urobilinogen, it will be taken up by the enterohepatic circulation. Some part will be, major part will be excreted through the stool as stercobilinogen, and some part will be excreted through the kidney as urobilinogen, it will form to urobilin. This is the summary, and you must remember all these steps right now. What I told, first formation of bilirubin by the reticuloendothelial system, just remember what I have so far told. Formation of bilirubin by the reticuloendothelial system, is it clear? Any doubt? Hello, I am asking you, any doubt about the summary? If you remain that side, you will not be able to see really properly. You might be smart right now, but try to remember, sit in this part of this, benches. So, then transported by in blood by albumin, uptake by hepatocytes, conjugation with glucuronide by glucuronil transferase, and then excretion of conjugated bilirubin in the biliary canaliculi, finally into the bile duct, entry of conjugated bilirubin into the biliary canaliculi through in the bile duct, formation of urobilinogen, enterohepatic circulation, and excretion of urobilinogen through urine is urobilin, and excretion of stercobilinogen in feces called stercobilin. That is the summary of the bilirubin formation and bilirubin metabolism basically. Now, coming to the clinical part. Now, you will find predominant conjugated hyperbilirubinemia in obstructive and hepatocellular jaundice. Why? Because in obstruction, already everything has happened, the bile is not able to flow. So there will be back pressure. So that conjugated bilirubin will regurgitate into the blood and it will cause conjugated hyperbilirubinemia. And in hepatocellular jaundice also, because it will not be able to deliver the conjugated bilirubin into the biliary canaliculi. In contrast, predominant unconjugated hyperbilirubinemia will occur with hemolytic jaundice. You must remember. Second thing, only conjugated bilirubin appears in the urine and that causes yellowish discoloration of the urine. And that's why the patient with jaundice present with yellowish discoloration at the OPD. Initial symptom, my urine has become yellow. Unconjugated bilirubin is not found in the urine because it is not water soluble. So, as I told you, catabolism of heme produces bilirubin. Now, the basic source is from RBC. Let us see what is the concentration of RBC in the blood. So, adult RBC is having 4.3 to 5.6 into 10 to the power 6 cubic millimeter. That is why we all express. If you convert it into liter, it will be like this. It will be 10 to the power minus 6, 10 to the power 6 also. In females, the figures are, all figures are almost less. So, if we take an average of 4.3 plus 5.6 for 4 plus 5.2, we will get an average of RBC count as 4.8. Now, different books give different figures and that really creates confusion and we don't know how normally the normal figures are. So, essentially central lab is giving another. If you see all the laboratories, if you find, as I told you earlier classes, you will not find the same figure everywhere in every lab because they have copied from somewhere else. So, the basic purpose why I am telling this thing for understanding purposes. See, cubic millimeter is basically microliter. So, 1 ml is 1000 microliter. So, 1 liter is 10 to the power 6 microliter. So, you see here, this is 10 to the power 6, this is 10 to the power 6, but that is in microliter. So, our college is reporting here, wherever you will work, you will get some amount of figures, but don't be satisfied, there will be guidelines in the book how, at what level the treatment has to be done. RBC count is like this. Now, coming back to this, that picture, this millimeter, cubic millimeter, this is 10 to the power 6, this is liter. So, that I have converted it here. So, 1 liter means 10 to the power 6, adult body contains 5 liter of blood. So, that is 24 into 10 to the power 12 RBCs will be there because 5 liters of blood are into there. So, 1 liter of blood will contain 4 into 10 to the power 12. So, 1 billion is basically 10 to the power 9. So, human adult blood contains 24 into 10 to the power 3 because this is 10 to the power 9, 1 billion. So, 24,000 billion RBCs are present in human body if the blood volume is 5 liters. So, normal destruction rate of RBC is about 200 billion. It's not a small figure, but that's a normal picture also. So, out of 24,000, only 200. So, 1 by 1/20th of RBCs are destroyed per day and similar amount is also being produced, so that you don't have any alteration in hemoglobin level. So this synthesis and breakdown process are uniquely correlated. So 1 gram of hemoglobin yields about 35 milligram of bilirubin. Human adults form 250 to 350 milligram of bilirubin per day. I repeat, this is derived mainly from hemoglobin, that is heme part of globin, and not majority part from other heme protein. And also, if there is a problem in the hemoglobin synthesis, this RBC formation, that is called ineffective erythropoiesis, or if there is any breakdown which will decrease the survival of the RBC or lifespan, it will cause alteration of the RBC size, then also you will get accelerated hemolysis, and that will cause increased bilirubin formation. So again, I am telling you, this book, various books are giving various figures. Now, bilirubin, if we measure the total bilirubin level, see, one thing you must do, that the normal figures of whatever tests are done in our laboratory, you remember these are the common tests and try to remember the normal values. That might be asked in your examination. So in Harper books, the latest edition, that book, the 2000 edition is called that 1 milligram, more than 1 milligram is hyperbilirubinemia, although the other books are telling like this. And I personally consider this 1 milligram to be the highest cutoff limit. Beyond that, one must be suspicious. And that's what I have practiced also. This is my own experience. Because usually an abnormality will be found if it crosses more than 1. So again, Shantinamani Medical College is reporting something wrong was there. I pointed out, it will be rectified. It has been rectified yesterday. So what is jaundice? So any increase of bilirubin will cause hyperbilirubinemia. There is no doubt about it. If it is more than normal level, that is normobilirubinemia. Now if it is more than that, then this is called hyperbilirubinemia. Now all hyperbilirubinemia will not cause jaundice, because urine has to be first and foremost yellowish colored, so that you will have a suspicion that you are passing a high colored urine. Otherwise, doubt will not be there. And until and unless bilirubin level is more than 2.5 to 3, this will not be visible. So you must remember what is jaundice. This you remember. Jaundice is a clinical pathological condition. You write down this thing. Characterized by yellowish discoloration of the sclera. Why sclera? Because sclera is the white part of the body. Its first staining will be found in the sclera itself. So we look at jaundice at the sclera first. If somebody complains about yellowish discoloration of the urine, first we check whether the sclera has been stained yellow or not. So it is yellowish discoloration of the sclera, and then if the level is higher, then the mucous membrane color, which is normally reddish, will also be yellowish. The skin of the palate, soft palate, will also stain, and the nail beds, which are normally white, will also be yellowish if the level is high or higher, normally not. When the nail beds are also yellow, that means that jaundice is very high, and that is remaining for a prolonged period of time. So this is caused by deposition of bilirubin in the tissues, the level of which is usually more than 2.5 to milligram per deciliter in the serum. And jaundice is a common mode of presentation in patients with liver disease. As characteristic sign or symptom which the patient will complain, that either yellowish discoloration of the urine, because yellowish discoloration of the urine can occur in concentrated urine. In the summer, perhaps all of you have noted that urine has been, color has been yellow, and the moment you drink a little bit more water, that normal color will appear in the urine. If you take excess of water, the urine will be watery because of the dilution of that pigment, urinary pigment. So the earliest sign will be, characteristic sign will be yellowish discoloration of the sclera because of the white. Now you see, these are all advanced cases. Although this has been dragged down, this usually sclera is, this upper eyelid is pulled up, so that a good amount of sclera is exposed. I will show you one during elliptic class also, I will demonstrate. Now normally the color of the serum, if you centrifuge, if you take a blood and then if you add anticoagulant or if you allow the blood to settle down, then the normal color of the serum will be like this. What is your problem? I told you to listen and remember. You cannot have much more important job than listening this class what I am telling. You cannot have. You will miss this thing. This normal color is just like normal urine color, slightly straw. But when the level of bilirubin will be high, that color, because of the bilirubin, that color will also increase. Now, as the level of jaundice will increase, the yellowish discoloration of the plasma or serum will also start increasing. Can you see the difference? Now, hyperbilirubinemia you will usually tell. In the laboratory, we get a sample and we do not tell hyperbilirubinemia, but we tell icterus. So, sclera is highly icteric. That will be, you will be noting, not hyperbilirubinemia. Sclera icteric. And this will write either 1 plus, 2 plus, 3 plus or 4 plus. If it is deeply stained, then it will be 4 plus. If it is slight, then icterus plus. Means yellowish discoloration is there. So that it will range from yellow to deep yellow to yellow orange to even high colored. So types of jaundice, there are 3 main types: hemolytic, hepatocellular and hepatic or obstructive. And I am telling you in my epileptic class, type of jaundice can be diagnosed from the routine epileptic parameters which are done even in our college without seeing the patient. That is possible. Diagnostic and binding, regardless of the clinical picture. That report you cannot ignore. And based on the report, treatment has to be given. Coming back to this picture which I have shown, so if there is any increase, normal there is every day we are at, as I told you, 120 billions of RBCs are destroyed. So that will cause normal amount of bilirubin. Now if there is an excessive hemolysis due to any cause, if there is a, RBC breakdown, then it will cause hemolysis. But remember, liver can take up at least 6 times its normal load. That means 1/6 of the liver can function, nor carry out normal body's function. So even that will not cause jaundice. But once that limit is exceeded, then it will cause jaundice. So hemolysis due to any cause will cause hemolytic anemia. And since this is occurring before it comes to the liver, it is called pre-hepatic also. So hemolytic jaundice, another name is pre-hepatic because it is occurring before liver. Now once that bilirubin is taken up by the liver, and if the liver cannot conjugate it properly or that there is a defect, that is called hepatic, and that is due to many diseases of the liver. So there will be defect in the liver. If the liver is diseased itself, so you will get a jaundice, and that is called hepatic jaundice. Now, after, as I told you in the earlier, in the another picture, there will be intrahepatic biliary duct, a right hepatic duct, left hepatic duct, common bile duct, and if there is any block in any form to the flow of bile, that will cause obstructive jaundice, and this from the entire tract. The hemolytic jaundice will be characterized because there is no problem in the liver, there is no problem in the biliary tract excretion. So, that will be characterized by only isolated raised bilirubin level, and that is arouse suspicion that this is perhaps we are handling with a case of hemolytic jaundice. Although the patient might not present, and that will be congenital, just like due to defects in the enzyme, or it can be acquired because something you have taken, some drugs you have taken that has caused hemolysis, or if there is a mismatched blood transfusion. By mistake, the blood transfusion has been given, and or even if blood transfusion has been given, there has been a destruction of the RBC, so that will cause a huge amount of RBC, there is a sudden overload, and that will cause a temporary one, not a permanent one, but those which are congenital, that will remain lifelong. The hemolysis, destruction of the RBC or the marrow precursor caused increased bilirubin production. That is the hallmark of bilirubin, hemolytic jaundice. But remember, as I told you, liver can take up as much as 6 times its normal load. So, bilirubin is usually mild. So, milder form of jaundice is found normally in bilirubin, but you will get a picture that hemoglobin level has dropped down or RBC count has dropped down, because that will not match. Again, that will be cause another suspicion that you are handling with a case of hemolytic jaundice. This remember, this part the liver can take up. So, liver has a tremendous power of regeneration. You have heard that one person can donate liver, part of liver, even up to 60% of the liver can be donated. So, that much liver also can grow into the transplanted person and also in the donor also. So, that the liver has a tremendous power of regeneration. So, hemolytic jaundice, another part is neonatal or physiological hyperbilirubinemia, that will be handling also in the pediatric cases. This is caused, it is a transient condition, because all babies are not normal, all ladies do not born, there may be some premature babies, some babies may be born, but with some amount of defect in the conjugation system or hepatic system for uptake and conjugation and secretion. Glucuronidase transferase activity is also reduced. If the importance of this case is that if the unconjugated bilirubin exceeds 20 to 25, that will exceed the capacity of the albumin to hold urine. So, that is being lipophilic, will enter into the cross the blood-brain barrier, and there will be bilirubin deposition in the brain, and that will cause bilirubin induced damage to the brain, and that is an emergency. Otherwise, there will be permanent damage to the brain. So, urgent treatment is given, phototherapy is given, and it will come down to normal. So, non-hemolytic hyperbilirubinemia, there are 5 different types. You need not remember all these things, at least you must be able to tell Gilbert syndrome. This is one disease which I want that you must be able to tell. Remember, there is a deficiency of glucuronidase transferase. So, glucuronidase transferase, if it is deficient, so it will not be able to conjugate. So, there will be unconjugated hyperbilirubinemia. So, this is usually mild, and there is a decreased uptake also. So, jaundice is in the form of very mild form, and there will be very much doubt that I do not pass yellowish color urine, my sclera is white and there is off and on either normal. He will be doing the bilirubin test in almost monthly interval in different laboratories. And one time he will get a normal report and another time he will get a slightly abnormal, but that will not be high and there will be a dilemma that whether my diagnosis, whether the laboratory is correct or not. Laboratory is correct, your body is at fault. You are having gluconeotransferase. In fact, I got a case, there is one, girl, I must not say, it's about 18 years age. Her bilirubin level at one point of time was normal, it was high, and she came to me and explained that perhaps it is a case of Gilbert syndrome. How to confirm? His father was so aggressive, how to get a confirmation? Then I said, this enzyme study is not available so easily, so go for the gene mutation. So there is a corresponding gene because this is a protein in nature. So UDP gluconeotransferase gene detection, and unfortunately that was not done. In Kolkata it was sent to Gangaram, and from Gangaram it was sent to USA, and finally it was detected to be positive. And she got a railway job at Shaktigarh and came back to me with that positive report. Then I told her, assured her that this is not a problem, it's a mild problem, you don't need to be worried. Don't ignore, don't give any importance, it's ignored. Kigler-Nazar in contrast, type 1, this is absent gluconeotransferase, so bilirubin cannot be conjugated. So high amount of unconjugated bilirubin will be there and it will cross the blood-brain barrier and it will stain the brain and there will be death, a rapid death in the neonate. Kigler-Nazar type 2, there is a mild moderate deficiency that is usually present in the neonate. There are another types of, that is Dubin-Johnson syndrome and Rotor syndrome. I am not telling this thing, at least at this bilirubin gluconeotransferase deficiency, you must be able to tell Gilbert syndrome, and that will cause unconjugated type of hyperbilirubinemia because of mild deficiency. So there will be many causes of hepatic jaundice which you will be reading in the clinical years. At least you must be able to tell hepatitis A, which is very common. Viral hepatitis, what is the common cause of hepatic jaundice? Viral hepatitis. A, B, C and E. A and E usually comes from water, contaminated water. If the water gets contaminated with the fecal matter, which happens particularly in the city, the sewage line are going, drinking water lines are going. In a planned city, it doesn't occur. But in an unplanned area, the sewage line is here and there, the drinking water line is here and there is leakage in the water line, and there is mixing. And that will cause contamination, and that's the common fecal-oral route transmission, and both viral hepatitis A and E are transmitted through water. And once it is water, means it is through food. Obstructive jaundice is another term, is cholestatic jaundice or post-hepatic, because it is occurring after the liver. So liver has conjugated its part. Now there is a failure in excretion. So that is called post-hepatitis. Why called cholestasis? Because there is a stasis of the bile. Chole means bile, so there is stasis. So that will cause obstructive jaundice. That again, there are many causes which you will be reading, and you have to encounter such type of cases. At least in the examination, you tell the obstruction to the biliary tract in the bile duct. So stone in the bile duct is a common feature. Gallbladder stone you must be here, you have heard. So if the gallbladder stone slips and enters into the bile duct, it will cause obstruction to the flow of bile, and it will cause obstructive jaundice and carcinoma of the head of the pancreas, because the bile duct is passing through head of pancreas. So if there is cancer, so that cancer cell will compress that bile, that structure I have shown, that there is narrowing of the biliary bile duct. So bile will not be able to flow. So how to differentiate? It's almost end of the class. I will tell all these things in detail, but by simply seeing conjugated level bilirubin level in the blood, you will be able to get an idea of what type of jaundice it is. So, in hemolytic, this will be increased. The unconjugated part will be more, because liver is normal, it has exceeded the capacity of the liver. So, unconjugated bilirubin will be high in hemolytic jaundice. In hepatocellular, because liver has conjugated, but it has failed to produce delivery to the bile duct, so it will be increased conjugated and unconjugated part will be less, and this will be again confirmed at the enzyme level, which I will not tell now, but later. And in obstructive jaundice, conjugated bilirubin will be very high, because liver has done its job. It has done the conjugation part completely, but there is a failure in the delivery. So, the entire bilirubin will be regurgitated back. So, there will be conjugated hyperbilirubin. So, that level will be very high. So, if you look at that urine, so in hemolytic jaundice, this part you remember, that urine will appear normal in color, but if you allow it to stand, because in hemolytic jaundice, because of the excessive hemolysis, excessive urobilinogen will be present in the stool, in the intestine, and that excess urobilinogen will be absorbed, and that will be excreted through the kidney. So, excess urobilinogen will be there, and on standing, the urobilinogen, excess bilirubin will be converted into urobilin, and that will cause darkening of the urine. Hepatocellular, it will be high colored urine, just like something, আমি সরষের তেলের মতো ইউরিন পাস করছি, এটাই নর্মাল কমপ্লেন করছে, ইউরিনটা ইয়েলো হয়ে গেছে, এখন তো সরষের তেলের মতো লাগছে। So, because of the high color of conjugated bilirubin. Obstructive jaundice, it will be very high, even at times slightly greenish, because some part will be converted into biliverdin also. Because of the obstruction, the normal color of the stool will not be there. The stool will be somewhat clay colored or whitish appearance. It will not be that yellowish. In hemolytic jaundice, the stool color will be dark, because the excess amount of urobilinogen will be converted into that stercobilinogen will be converted into stercobilin. And depending on that degree of block, hepatocellular jaundice either will cause a slightly or slightly whitish. So, as I told you earlier, that's something you have to contribute before you die. So, I had contributed two things on hyperbilirubinemia. One was as a first year PG student, or first year, after MD student, the HOD of my department wanted me to write 2 chapters in a book, and this was published from Sir Gangaram Hospital and AIMS. He was the HOD when I was an MD student, and later he became HOD, this Dr. Subrata Sinha. And this I contributed in November 1991, and that was published from Gangaram Hospital in 2002. These 2 chapters have been written. One was glucose, one was liver function test. Second part, I found in my entire professional career one peculiar case. The serum color was normal, just like a straw colored, but it gave it's a very high level of bilirubin. Bilirubin was of the range of 10. So I was really in a dilemma, what is the cause? Everybody was, our laboratory staff did not want to release the report, but I went through this thing, and the exact summary is found in the internet. If you find in the Google the false high bilirubin in non-ectatic serum, you will find my paper, and that was published in International Journal of Biological and Chemical Sciences in February 2017. And that's the unique explanation I have given. other people have described it, but nobody could explain the why it happens. So with that, I conclude here. I read this topic. If you cannot understand anything, ask me questions.
Okay, so today is a repeat and revision class. So can you people tell me what is hemoglobin? It is a red oxygen carrying pigment present in the RBC. Okay, it is responsible for delivering oxygen from the lungs to the tissues. Okay, so what is this? I have taken the components outside. Okay, this entire thing is known as hemoglobinometer. Now see, this is the hemoglobinometer tube. It has got two gradings, one in the yellow color and the other in the red color. So, because you guys have done, so try saying what we will do with this. What is the first thing to be putting in it here? Yes, very good. So, see, this is the N/10 HCl, but in lab they are giving you distilled water in this. So, we will be adding N/10 HCl up to this 2 gradation mark. Okay, we will add it up to this 2 gradation mark, and then what you will do, you will place it in the comparator box. Now, what is this comparator box? See, this is a plastic box. Okay, it is used for comparing. What you will compare? See, after you have added the N/10 HCl up to the 2 gradation mark, next thing what you will do? Yes, see, you will clean the middle finger or the ring finger of your hand with spirit, and then what you will do? You will wait for 4 to 5 seconds for the spirit to dry. Don't prick it immediately. What will happen? Because if you prick it immediately, the blood will be displaced. Okay, and it will be difficult for you to draw the blood into the pipette. So wait till it gets dries and then draw the pipette. Till how much, till what mark you will draw? 20. Yes, very good. And then what you will do? Sorry, I'm a bit nervous. My hands are shaking. Sorry. See, you will insert this entire thing into this tube. Okay, then what you will do? Discharge the blood. Discharge the blood. Okay, then take this pipette out. Insert this stirrer. The flat end of this stirrer. Okay, then mix it with this stirrer and then insert it again into this comparator box. Okay. So, what is the principle of this experiment? Can anybody say? What is the purpose of adding the blood into this N/10 HCl? See, this N/10 HCl, it is a diluted hydrochloric acid solution. The acid present in the hydrochloric acid will cause, as immediately it comes in contact with the blood, it will cause the rupture of the RBC membrane and release of the hemoglobin into the solution. This is the basic principle of this experiment. Conversion of the hemoglobin into acid hematine under the presence of diluted hydrochloric acid. Okay, now why not strong acid and alkalis are taken? Why diluted hydrochloric acid is taken? See, when you will add strong acid along with the rupture of the RBC, it will also cause the rupture of the hemoglobin. And that is not the purpose of this experiment. You will not get the accuracy of the result. You only need to you need to dilute it so that RBC gets ruptured and hemoglobin comes into the solution. Now, for how long will we allow the solution to stand? Why? Yes, you are saying it right. Why? Why not more than 10 minutes or why not just 5 minutes? Why not to hang around for 15 minutes and let the solution, See, you will have to allow for a minimum of 8 minutes so that all of the hemoglobin gets converted into acid hematine. If you do not wait for a minimum of 8 minutes, then there will be incomplete conversion and inaccuracy in the result gate. And if you wait more than 10 minutes, then what will happen? The color that has already formed, it will start to fade. You have to remember one thing, all of the hemoglobin that is formed into acid hematine, it is the concentrated form. After the entire conversion of the hemoglobin into acid hematine, the solution is not going to get any more concentrated. If you keep it for longer minutes thinking that it will get more darker, no. The light will start to fade. So, you will have to keep it for a maximum of 10 minutes. Now, after 10 minutes, what you will do? And what is the color formed? Color of the acid hematine formed? Dark golden brown in color. Okay, it is dark golden brown in color. And the intensity is directly proportional to the concentration of acid hematine formed, which is proportional to the concentration of the hemoglobin present in the blood, from whom the blood is being drawn. Okay. So, next is, see why you will have to keep this stirrer inside in the entire process. Why? Why you will won't take this stirrer outside? Try, tell anything. See, you will have to mix the solution. Very good, you are right. You will have to mix this solution a lot of times. Okay, first you are mixing it while you have added the blood. Okay, then again after 10 minutes, what you will be doing? You will take the dropper and you will start adding distilled water into this solution. Drop by drop. Do not add a lot of distilled water. Why you will add it drop by drop? Slowly the color will start getting lighter and you will have to hold it and compare. See, you will then have to hold it and compare it against the sunlight. For this, it is known as the comparator box. The color that is formed after the addition of the distilled water will slowly start turning lighter in color. And at one particular point, it will match the color of these two glass tinted rods. These two yellow glass tinted rods. Okay. So, now why distilled water is only added? Why not N by 10 HCl? N by 10 HCl is also a transparent solution. Why will add only? Sorry? Yes. It is costly. That's why we will add only N by 10 HCl. And we will add distilled water. But if distilled water is not available, which is not possible to not get it, we will add N by 10 HCl. Okay. Now, yes. So every time you are mixing the solution and you are taking the stirrer outside, what is happening when you are adding the distilled water? You have to mix the solution. So every time if you remove the stirrer outside, some amount of solution will keep coming out of the hemoglobinometer tube. So again there will be difference in the result you get. It won't be the accurate one. Now when you are matching the result against the sunlight, you are comparing it with the two glass rods, then you will have to keep the stirrer outside above the solution. You will just pull it above the solution. Above the solution. Why?
Because the refractive remains of the stirrer.
See, it is a, don't make it so difficult or, the words of the book. It is a glass rod. It is a glass rod. The color will appear more lighter. Okay, the color will start appearing more lighter because it is a glass rod and it is also interfering with the color you are getting. So, you will have to pull it and keep it above the solution. That is the simple thing. Okay, now, see, can you tell me the levels of the hemoglobin in different age group? In newborn, what is the level of the hemoglobin in the newborn? In the adult male and in the adult female? Level of the hemoglobin in the adult male and in the adult female and in newborn. Males কত হয়? হ্যাঁ বল? হ্যাঁ 14 to 16 males আর females হ্যাঁ 12 to 14 এগুলো তো মুখস্থর জিনিস। ঠিক আছে? In newborns how much it is? How much the hemoglobin level in newborn? It's 20 to 22 gram per dl. Can you tell me why? Why the newborns have such a high level of hemoglobin and RBC count? 20 to 20 gram per dl hemoglobin count means RBC count will be more than almost 6 million per cubic unit of blood. So why? See, in the pregnancy, in the later stages of gestation, what is the fetus is drawing the blood, oxygen from the maternal circulation. So what is happening? It is living in a state of relative hypoxia. So this in itself is a potent stimulus for erythropoietin secretion. Now what is erythropoietin? Without erythropoietin, your erythropoiesis cannot get initiated no matter how well functional your bone marrow stroma is. Okay. So these erythropoietin, whenever your hemoglobin level, whenever the partial pressure of oxygen is low in the blood, this erythropoietin is secreted from the kidney. This will go to the bone marrow, this will stimulate erythropoiesis and RBCs will be increased. So in the later stages of gestation, the oxygen demand of the fetus is more. Oxygen demand of the fetus is more. So erythropoietin secretion will be stimulated, erythropoiesis will get initiated, accelerated, and there will be more RBCs production. So that's why the fetus has more hemoglobin than the normal adult and the males. Now why adult is having more hemoglobin than the female? Idhar bhi gender inequality kyun? See, one reason you know, one basic reason you know. Again, main tab all women of the reproductive age group. See, India is a nutritionally deficient countries. Okay, menstruation is a very big cause for women to be having low blood group levels, low hemoglobin, because we don't take, our intake of the protein and nutrient is not that much good like as those of the affluent countries. Okay, so this is the first basic cause. And then the what you are saying, androgens and estrogen, say? Say, try saying. See, the estrogen hormone present in female, they have somewhat inhibitory effect on the erythropoietin formation, and the androgen present in male have somewhat stimulatory effect. Okay, now can you tell me, based on the degree of the hemoglobin, concentration of the hemoglobin, can you classify anemia? What is anemia? What is anemia? What? Was any one of you say? Any one of you, particular, any single person say? Bol, tu bol. It is not a physiological condition. Anemia is a pathological condition. Physiological is the normal condition. That is, when you say it's a physiological condition, a pregnant female having low iron levels or having low hemoglobin, it's a physiological condition. Women of the reproductive age group, it's a physiological condition. But anemia, if somebody is significantly having low levels of hemoglobin in the blood, it is not a physiological condition. What is the difference between physiological and pathological? Pathological is a disease state and physiological is a normal state. Okay. So anemia is, no, yeah, but definition of anemia. Exactly, due to which there is decrease in the oxygen carrying capacity of the blood. Now, can you say mild anemia based on the hemoglobin levels? What will be the value? Try any value. Mild, moderate, severe. There are 3 types of anemia based on the classification of hemoglobin levels. Mild, moderate, severe. What is mild anemia? Yes, say 10 to 12 gram per dl. Moderate is? No, not 10. 10 to mild chale asche. 7 to 9 or 8 to 9. And severe? Less than 6. Increase in the causes of increase in the RBC level in the blood, physiological and pathological. Tell the 2 causes. Physiological cause of increase in the RBC, see, it's directly proportional. If the RBC is more, the hemoglobin level will be more. If the RBC is less, then the hemoglobin level will be less. Okay. So, physiological causes of the increase in the RBC level in blood. এক্ষুনি বলেছিস একটা আসছে তার আগে এমনি নরমালটা বল কাদের মধ্যে বেশি থাকে ছেলে না মেয়ে মেলস ওকে দেন ইয়েস হাই অল্টিটিউড why in high altitude see the explanation is same okay the questions will be different but the explanation কিন্তু ঘুরে ফিরে একই আসে what will happen in high altitude exactly so what is happening oxygen level is less now what is happening what are the changes going on inside the body because of this less oxygen hypoxia there is decrease in the oxygen level in the blood okay so oxygen concentration is low in blood it will be stimulating the endothelial cells of the peritubular capillaries in the kidney in the advanced stages in final year you will learn why renal failure patients suffer from anemia the kidneys are damaged so there is no erythropoietin secretion if there is no erythropoietin as I said erythropoiesis cannot occur doesn't matter how well function of the bone marrow is so yeah very good now pathological condition lung diseases chronic heart diseases anything that is not able to if the heart is not functioning it won't be able to pump the blood pump hi nahi hoga to oxygen who will carry the oxygen other than the RBC okay so and the physiological causes of decrease in the RBC level or the hemoglobin level in blood physiological তো আবার ভুল বলছিস blood loss কিছু একটা যদি হয় blood loss কিভাবে হবে তুই বল you may accident injury hote pare you may vomiting of blood is known as hematomasis there may be bleeding hemorrhoids so these are pathological states physiological again females of the reproductive age menstruation is a physiological cause women of the reproductive ages later stage of gestation when the mother is carrying a baby the requirement of the oxygen the requirement of the blood will be the more by the body okay and pathological now say pathological causes of decreased anemia main is anemia all the kinds of leukemia anything nia means decrease okay decrease in the level of the blood anemia leukemia hemorrhoids okay hematomasis anywhere where you are losing blood from the body losing of the blood from the body is not normal if you say that I am vomiting blood then it's not a normal condition okay you'll have to get yourself checked by the doctor so experiment থেকে সরে গেলাম থিওরি পড়তে গিয়ে আমাকে বকবে এবার so can anybody come and monitor the experiment can anybody tell the experiment what you will be doing start from the first okay any questions are there you related questions you need to know regarding the experiment see first tell along with me what is this box known as say exactly sorry I haven't mentioned that Sally's hemoglobinometer okay this experiment is known as that what is this hemoglobinometer tube it has got how many gratings Two gradings, one in the red color and one in the yellow color. Which one we will use? One in the gram percent, because it is getting more accurate. Then what is the next thing? What is this? N by 10 HCl. What we will do with this N by 10 HCl? First is we will be taking this N by 10 HCl. What we will do with this N by 10 HCl? With a dropper, with the help of a dropper, we will be adding it till the mark 2. Okay. Then after this, what we will be doing? Next step by step. Remember, step by step. Yes, you will be pricking the finger under aseptic condition with a sterilized needle. Now, what is needed for that? A cotton and a spirit. Now, what you will do? Why you will wait for 3 to 4 seconds until it gets dry? Why? Because if you prick it, these are the tricky questions that the examiner may ask you in your prof. Okay, why? अचानक से पूछ ले क्यों भाई? Why we won't prick it immediately after applying the cotton swab? See, it will exactly, the blood will get displaced and it will be difficult for you to draw the blood in the pipette. Okay, so you'll be drawing it up to this mark, and then what we will do next step? What you will do? You'll be entire pipette into this hemoglobinometer tube. Why you will put the entire pipette into the tube? So that no amount of blood is getting outside. Okay, it might be sounding a bit irritating, but accuracy is everything. 1-2 mistakes is okay. But if you make a lot of mistake in every step, then there will be a huge difference in the result. And that is not the motive of the experiment. So after discharging the blood, what you will do? Next step is? Yes, next step is you will take this stirrer. Which end you will insert? This flat end. And then you will mix it. And then what you will do with this stirrer? You will keep it inside the tube. And then you will allow this comparator box to stand for how many minutes? 8 to 10 minutes. Why 8 to 10 minutes? Why not more than 10 minutes? Okay, first tell me the principle of this experiment. What will happening in this solution inside this tube for the 8 to 10 minutes time in which you are keeping it? Acid hematine is formation of acid hematine. Hemoglobin is converted into acid hematine in the presence of the dilute hydrochloric acid. Okay, why we are taking the strong acids and why we are not taking strong acid and alkali? It can cause the rupture of the hemoglobin. Now, why to wait for only 10 minutes? Color will fade. And if you do not give a minimum of 8 minutes, what will happen? There will be incomplete conversion of the hemoglobin into acid hematine. Now, okay. Why this stirrer should be kept inside all along the experiment? Yes, not the loss of hemoglobin, lost the solution. You are not your solution won't get lost. Okay. Any added questions you need to know? Any extra questions you feel you want to ask regarding this experiment? Can tap water be used instead of distilled water? Why? Yes, so what will happen? The solution will get turbidity এসে যাবে ঠিক আছে Okay, I'm not getting any more questions, so I think you can get started with the experiment. Do you need to know anything else regarding the experiment? Just think. Okay, what are the recordings that you will be taking? What are the recordings? I have been told, I have been asked to tell you people that 3 recordings need to be taken. What are the 3 recordings?
First one, the color will be a bit darker than
the concentration of the acid hematine. When you think that the acid hematine has formed after 10 minutes, when you see that it's a dark brown color, you will record that reading. Okay, then the next reading?
When it is slightly darker than the other.
No, it won't get darker. Once it has got, I have already told you. Once the entire hemoglobin has converted into acid hematine, the solution cannot get any more darker. So if you exceed more than 10-12 minutes, it will start fading in color. It will start to fade in color. Okay. The color you get approximately after 9 to 10 minutes is the actual color, and you need to record that color. That is the final color of the concentrated acid hematine, which is describing the concentration of the hemoglobin. Now you will be adding distilled water and you will be making it lighter so that it matches with the color of these 2 glass tinted rods in the comparator box. Okay. So at one point when the color will match with the color of the glass rods, that is your hemoglobin level. Okay. At one point it will match. So you will record that at which the solution color is matching the solution of the color of these 2 glass tinted rods. That will be your hemoglobin percentage. Now you will add further distilled water. See, your experiment is over at that time only. When the color matches, the experiment is over. You have gotten your required value. You have gotten your estimated designated value. Now, why you will add more distilled water? The solution will get more lighter. It will get lighter than the 2 glass rods. You will record that reading also. Okay, these 3 readings have been asked to get recorded. Okay.
Okay. So in between the internal intercostal and the intercostalis intimus, here lies the neurovascular bundle in the costal groove. Okay. Structures from above downward is posterior intercostal vein, then posterior intercostal artery, then nerve. Okay, intercostal nerve. So these VAN from above downward. So you have to see these 3 structures in the posterior intercostal space. Okay, so the thoracic wall, it is covered by skin with nipples and areola. This is the superficial most. After reflecting the skin, you will get the superficial fossa with the mammary glands. Okay, and then you get the deep fossa. Deep fossa is the pectoral fossa in this thoracic region, upper part of the thorax. Pectoral fossa covering the pectoralis muscles. After reflecting the pectoralis muscles, pectoralis major and pectoralis minor, you will get the intercostal spaces along with the intercostal muscles in between the ribs. So muscles are intrinsic and extrinsic muscles. See, these are the 2 ribs. In between the 2 ribs, these are the muscles: external intercostal, internal intercostal, innermost intercostal, or intercostalis intimus. And these are the structures in the costal groove: vein, artery, and nerve. And these are the collateral branches of these structures. Okay, so content of a typical intercostal space is external intercostal, 3 muscles. Those I will discuss: external, internal intercostal, and intercostalis intimus, or innermost intercostal. Another thing is intercostal nerve, then posterior and anterior intercostal arteries, intercostal veins, lymphatic vessels, and lymph nodes. All these are content of a typical intercostal space. You will see the muscles, artery, vein, and nerve, and lymph vessels. These are very fine. You cannot see these lymph vessels, and lymph nodes has been removed. Okay. রাজি হচ্ছে না। কোনো কিছু নিজের ইচ্ছা মতো চলছে, ওটা কন্ট্রোল করা যাচ্ছে না। আচ্ছা, okay, okay, intercostal muscles, 3 intercostal muscles you have to see: external, internal, innermost intercostal. Other intrinsic muscles are the subcostalis, sternocostalis or transversus thoracis, levator costorum, and serratus posterior, superior, and inferior. These are the other intrinsic muscles. Now you see the external intercostal. See the fiber direction. Direction of fiber is downward, forward, and medially. You can see the red arrow. Okay, downward, forward, and medially, and it is replaced by anterior intercostal membrane in front. Okay, external intercostal, it is replaced by anterior. It is continuous with the anterior intercostal membrane in front. Next is internal intercostal. Fiber direction is just at 90 degree with the external intercostal. Fiber direction is downward, backward and laterally. Okay, and it is replaced posteriorly by the posterior intercostal membrane. Okay. Now, innermost intercostal or intercostal is intimus. It is present only in the middle 2/4 of the intercostal space. Previous to external and internal intercostal, it was lying in the whole of the intercostal space, but intercostal is intimus is lying only in the middle 2/4 of the intercostal space, and fiber direction is same as internal intercostal, that is downward, backward and laterally. And see the origin is from the middle 2/4 of the ridge above the costal groove, and insertion is into the inner surface of the rib. Okay, so this is the origin and insertion. Now another is subcostalis. See, these are the subcostalis, fibers of subcostalis. Origin is inner surface of the rib near its angle, near the angle of the rib. And insertion is into inner surface of second or third rib below. Okay, in see here, second rib below, almost all the fibers are inserting second rib below. So this is subcostalis. You will see this in the posterior part near the angle of the rib. Now transversus thoracis. It lies just behind the sternum and anterior thoracic wall. See, just behind this, here is the sternum. These are the costal cartilage. Just behind the sternum and costal cartilage, the fibers are lying. Origin is from the lower 1/3 of the body of the sternum, xiphoid process, and costal cartilages of lower 3 to 4 true ribs. Our insertion is into, here is the origin. Insertion into the inner surface of second to sixth costal cartilage. Second to sixth, second, third, fourth, fifth, and sixth costal cartilages. Okay, so this is the origin and insertion of transversus thoracis. You will also see this. And another names of this is triangularis sterna or sternocostalis. Now intercostal nerve. Okay, see, this is intercostal nerve. This is the ventral ramus of the thoracic nerve. Okay, it is giving muscular branches to the intercostal muscle. There is the dorsal rami, and this is the lateral cutaneous branch. Divides into anterior and posterior branch. And anteriorly, it pierces the internal intercostal and anterior intercostal membrane to become continuous as the anterior cutaneous nerve. Okay, so this is the course of the intercostal nerve. And intercostal Okay, intercostal nerves are classified into typical intercostal nerve and atypical intercostal nerve. Typical nerves, they are confined to only the thoracic wall, and third to sixth intercostal nerves are typical nerves. And atypical intercostal nerves, in addition to thoracic wall, they will supply other structures, additional structures. First, intercostal nerve form the lower trunk of brachial plexus. Second, it gives a branch, lateral cutaneous branch, that is intercostobrachial nerve. You have seen this during the superior extremity dissection during the axilla. Okay, It was supplying upper part of the medial surface of the arm, supplying the skin of the floor of the axilla and upper part of the medial side of the arm. And 7th to 11th intercostal nerves, it supply anterior abdominal wall. Okay. So these are the typical is confined to chest wall, 3rd to 6th. Here atypical is first, second. First is lower trunk supplying the lower trunk, second intercostobrachial nerve, and 7 to 11 abdominal supply. That's why atypical. This is the course. See the branches and the intercostal nerves, they are connected to the sympathetic ganglion via the gray and white rami communicants. Okay. So these are the branches. Rami communicant is muscular branch for intercostal muscles, collateral branch, lateral cutaneous, anterior cutaneous branch. This you have seen three muscles. The neurovascular bundle lies between internal intercostal and intercostal intimus. Okay. So the relation of neurovascular bundle from above downward, it is posterior intercostal vein, then artery, and then nerve, VAN, from above downward. This is very, very important, this relation, VAN, from above downward. Okay. Okay, different branches has been shown, muscular branches, lateral cutaneous, anterior cutaneous, dorsal. Okay, so this is peculiarities of first intercostal nerve. It is atypical intercostal nerve, contribution to the lower trunk of brachial plexus. Forms lower trunk of brachial plexus by joining with C8 and runs under the first rib due to the absence of the costal groove. No collateral and anterior cutaneous branches. Okay, thoracocentesis. This is a clinical aspect. Thoracocentesis is done along the upper border of the rib. And this has been, I have told you in the lecture cell. Okay, this is done at along the upper border of the rib to avoid injury to the neurovascular bundle, which is lying within this costal groove. Thoracocentesis is done in 8th or 9th intercostal space in the mid-axillary line along the upper border of the rib to prevent the intercostal injury to the intercostal nerve. And herpes zoster is a viral infection may spread to the skin supplied by the same cutaneous nerve and produces vesicular blisters. See here, only this space is involved. Blisters are involving only this space. Okay. Specific intercostal space is involved. And dorsal root ganglia, virus remain active in the dorsal root ganglia. Okay. This is the dorsal root ganglia. Now the arteries. Intercostal arteries are posterior intercostal arteries and anterior intercostal arteries. You can see posterior intercostal artery is branched from the aorta. Okay. Anterior intercostal artery branched from the internal thoracic artery. And each of the posterior intercostal artery also giving a collateral branch, and these two branch anastomosing with the one pair of branch for each space in the upper 6 spaces from the internal thoracic. The arteries are anastomosing with each other. Okay. Here you can see the right posterior intercostal artery. Aorta is lying on the left side. So length of this right posterior intercostal artery is more because the artery have to cross in front of the vertebral body and go to the right side from left to right. And here is the left posterior intercostal artery. this sympathetic trunk. On the left side there is hemiazagus vein, on the right side there is azagus vein, and here is the thoracic duct, and in front of the aorta here is the esophagus. Okay. Okay, so posterior intercostal arteries, first and second arising from the superior intercostal arteries, third to 11th from the descending thoracic aorta, and they are occupied, each intercostal space is occupied by one posterior intercostal artery. See the branches, and this superior intercostal artery, it is a branch from costo-cervical trunk, okay, which is a branch of subclavian artery. And from third to next branch from the descending thoracic aorta, you can see. And first two is branch of superior intercostal artery. Okay, they pass as a vein structure along the intercostal space, and then anastomosing with the upper anterior intercostal artery. This is the termination. Here you can see the course. Now what are the branches? Dorsal branch, here also like the nerve, like the branches of the nerve, mainly the branches are coming. Okay, so dorsal branch, one collateral branch, muscular branches to adjacent muscles, lateral cutaneous branch, and here is the lateral cutaneous branch. Mammary branches, external mammary arteries arise from second to fourth posterior intercostal arteries, and they supply the mammary gland. And right bronchial artery arises from the right third posterior intercostal artery. Okay, so there are 9 pairs of anterior intercostal artery. That was from the posterior intercostal artery branches. Now anterior intercostal arteries, 9 pairs. Each intercostal space contains one pair of anterior intercostal arteries as upper and lower. Here you can see branch from the internal thoracic. Only upper 9 intercostal spaces have anterior intercostal arteries. First to 6th pairs arise from the internal thoracic, 7th to 9th pairs arising from the musculophrenic. Okay, this internal thoracic artery is dividing into two branches, superior epigastric and musculophrenic. Musculophrenic is giving branches to anterior intercostal arteries. Okay. In case of coarctation of aorta, there becomes reed notching is present. Okay, here reed notching has been shown. Now intercostal veins. These are the course of the vein has been shown. Okay, anteriorly it drains into internal thoracic vein, and posteriorly it drains into azygous and hemiazygous system of vein. Okay. Azygous system of veins. So intercostal vein, each intercostal space contains two anterior and one posterior intercostal veins. 10th and 11th intercostal space do not contain anterior intercostal veins. So anterior intercostal veins are 9 pairs. Only upper 9 intercostal spaces have these anterior intercostal veins. Okay. Termination, first to 6th pair drain into internal thoracic vein, 7th to 9th musculophrenic vein, like the arteries. Okay, and posterior intercostal vein, there are 9 posterior intercostal vein on each side, one for each space. Okay, and they are draining into the azygous system of vein, like this. On the right side, they are draining into azygous vein. On the left side, second, third, and fourth join to form the superior intercostal vein and drain into the left brachiocephalic vein. First is directly draining into the brachiocephalic vein on the both sides, and 5th to 8th forming the accessory hemiazygous, and 9th, 10th, 11th, 12th forming the hemiazygous vein crossing the midline near the C8, C7 and C8 level, and draining into the azygous vein. So these are the drainage of the posterior intercostal veins. See, this is the position of the arteries, anterior intercostal. Okay, and this is internal thoracic artery or internal mammary artery. Okay, this counts as a short note for you. Internal mammary artery or internal thoracic artery. Okay, and these intercostal spaces are important for long question. Course of a typical intercostal nerve. Important question. And drainage of the veins, intercostal veins are drainage. Also, an artery course of the branches, it is branches of which artery, all these are important long questions for you. Okay, and this internal thoracic artery comes as a soft note. So, internal thoracic artery, also called internal mammary artery, deep to the anterior chest wall on either side of the sternum. Origin arises from first part of the subclavian artery. See here, this is internal thoracic artery is descending. It is a branch from the subclavian artery, first part of the subclavian artery. Termination, it ends by dividing into superior epigastric and musculophrenic. See here, it is dividing into superior epigastric and musculophrenic arteries. Okay. So origin from subclavian artery runs vertically downward behind the upper 6 costal cartilages, and branches are pericardiophrenik, mediastinal, perforating branch, anterior intercostal branch, and terminal 2 branches, superior epigastric and musculophrenic. And clinical importance, this is useful for coronary artery bypass graft. Okay, CABG. Okay, most commonly done nowadays during any blockage in the coronary arteries. See, these are the branches, mediastinal branches, pericardiophrenik branches supplying the pericardium of the heart. These are the perforating branches, and here are the anterior intercostal arteries, and these two are terminal branches, superior epigastric, musculophrenic. Okay, so these are branches of the internal mammary artery. Okay, so here you can see the internal thoracic artery has been used as the coronary artery bypass graft. See, this is the artery supplying branches of coronary artery supplying the heart, and this blue area is the site of blockage. So the artery has been cut and anastomosed with distal part of the artery, distal to the blockage. Okay, that's how coronary artery bypass graft is done. And why it is done? Because there are late stunts of atherosclerosis in this artery, and it is histologically more similar to coronary arteries, and its endothelium produces more antithrombotic molecules, that is heparin, plasminogen activator, etc. And these prevent further clot formation, further blockages. Okay. And another clinical aspect is rib composite flannel thoracic artery is useful for reconstruction of the mandibular defects. Okay. See here the coronary artery bypass graft. The internal thoracic artery has been attached distal to the site of blockage. Okay. So these are the clinical aspect. Okay. So what you have to see in the intercostal space? First, we are reflecting the skin and superficial fossa. Within the superficial fossa, you get the nipple and areola. After that, you will get the deep fossa. Deep fossa was covering the pectoral muscles. Pectoralis major and minor. That has been removed. After that, you will get the ribs and the intercostal spaces. In the intercostal space, you will see the three intercostal muscles from outside inward, external intercostal, internal intercostal, and intercostal is intimus. External intercostal, you have to identify these muscles according to the fiber direction. Okay, external intercostal, like you are putting your hand in your pocket, downward, forward, and medially. Okay, internal intercostal is exactly at 90 degree with the external intercostal. It will be directed like this, downward, backward, and laterally. Okay, and intercostal is intimus, same as the internal intercostal. Fiber direction is same as the internal intercostal. And the band structure, neurovascular bundle, it will lie in between the internal intercostal and intercostal is intimus. Okay, then these structures, intercostal vein, artery, and nerve, this we will see in the posterior intercostal space. Also, we will see the sympathetic chain and connection of the nerve with the sympathetic chain, that we will see. And you will see the pleura. The pleura on the inner aspect, covering of the pleura. Costal pleura is covering the ribs and the spaces separated by the endothoracic fossa. And also you will see this internal thoracic or internal mammary artery, you will see. Okay. So all this for today. Okay. Now you come in batches and see. Come according to roll numbers. Okay. Three batches you come. 1 to 25, and seers control them and take to the dissection hall. 1 to 25, 26 to 50, and then 51 to 75. Okay.